Wonderful. Can we see it?
I have it.
Awesome.
Okay, this is a 64-year-old white woman with a lot of things going on. She's had rheumatoid arthritis for many years. She now has ankylosing spondylitis. She's becoming more and more debilitated. Her neck movement is now to the point where she can't really drink out of a glass. She has to use a straw. She can't look up. She can't change a light bulb on her own, that kind of thing. She also has the restrictions in her lower back. She was on disease-modifying agents for a long time, but then developed a renal cell cancer, which has been successfully treated with surgery. But she's had to come off the immunosuppressants. And because of that, her spondylitis has been progressing fairly rapidly over the last couple of years. It's also limited our options for pain management. We really can't use nonsteroidals or anything that's going to damage her remaining kidney. She's diabetic, hypertensive, GE reflux. She describes her pain as being worse in the morning, worse on rainy days. She sets the alarm half an hour earlier than she used to in order to get going. She's actually, she's the eternal optimist. I mean, she's kind of taken all this in stride, but anyway, she's obese. She moves very stiffly. She can't look up, can't extend her neck. She's got the rheumatoid deformities of her hands. She's not really got a diagnosis of anxiety or depression. She seems philosophical about all this. She's divorced. She's got a daughter who's a nurse who lives nearby and a daughter who's a nurse practitioner who lives a couple hours away, but I mean, they're very supportive. She lives by herself. And she says, yeah, she said that would get me down if I let it, but I'm not going to let it. Although some days that's hard. She's given up a lot of the activities that she used to enjoy, crocheting, really getting out of the house and that sort of thing. Her medications are listed there: glimepiride, enalapril, HCT, pantoprazole, hydrocodone 10-325, which she takes 4 times a day. We occasionally use short-term nonsteroidals if we have to for a week or two, just to kind of get her through a rough patch. And it's not really that she's failing medication. She feels like things are pretty well controlled on what she has. Looking at her pain scale, actually being scrolled down a little bit more, Caitlin, so we can see the questions. Yeah. But it is interfering to a degree with her activity, with her sleep, with her stress, that sort of thing. I mean, I think if she was being honest with it, it's interfering more with activity than she's telling us. But I feel like the hydrocodone QID is keeping her functioning. The problem is we're getting notifications from her pharmacy that we have to switch her to something long-acting, or they'll only fill a 7-day supply. I kind of unknowingly tried switching her to like something else that would be the same amount of hydrocodone. That's actually not going to work out. Insurance says I have to use Dilaudid. I found out this morning that maybe I could tell her to change pharmacies instead of changing medications. But it is kind of a question when we've got somebody like this on something that's considered short-acting but is keeping them functioning. Is there a reason other than regulatory to switch them over to something long-acting? And if so, how do we go about making that switch? So that's my question.
Thank you, Dr. Rexford. That was a wonderful case. I'm going to ask people out there, Jennifer and Lucia, do you guys have any comments? Have you guys run into this at all?
Well, I haven't in a long time, and I know that was I think I like the way Dr. Rexford put it. Is there a reason other than regulatory? To be honest with you, I haven't had people on, I have very few people anymore on short acting, and I don't have anybody on long acting, but I mean, I know that for a long time that was the conventional wisdom was to switch to long-acting. But I have the same question. I have had the same questions that Dr. Rexwood just asked in the past about similar patients who are fairly well maintained on a short-acting. My question for Dr. Rexwood, is she's using it QID, is that what you said?
Yes.
And that's, I mean, she takes 4 a day no matter what.
Pretty much does take 4 a day. Like I say, she kind of sets the alarm and takes one to get up and get going, and then, yeah.
How long have you had her on this?
Oh, I can tell you here in a couple of clicks. It's been at least a couple of years. I kind of took over prescribing for her a couple of years ago. She'd been seeing one of our mid-levels at a satellite clinic, and I now go there, you know, for people like this so that we have somebody there seeing them who can prescribe. This particular regimen has been, I'm just looking. It's been a couple of years. I mean, it's been like 2 to 3 years that she's been on this particular regimen.
So according to the Opioid Reduction Act, if a patient's been on chronic opioids before 1/1 of 18, they don't fall under that rule, okay? That doesn't mean that the pharmacy won't have in their region other rules that are more strict. But you're perfectly fine within the law to continue 4 times a day of a lesser potency drug than the drug they recommend that you have to use. As long as you're doing all the things we always talk about, which I know you do because you always tell us, you know, it shouldn't be an issue. Now, will it? What I would suggest to you is that you contact West Virginia SEMP, Safe and Effective Management of Pain, and we can get you that information and talk with the director there who has direct contact with utilization review, a rational drug, if you will, and can maybe help you out, because this just doesn't make any sense. I mean,
well, what I'm learning is that I think this is the particular pharmacy, because I spoke to another pharmacist this morning who said, yeah, it should be fine. So,
yeah.
I mean, I can't legally, I guess, tell her which pharmacy to go to, but I guess I could make suggestions.
Yeah, I mean, not working.
I think you can. Hey, Dr. Rexroth, this is Charlie. I just have a question, just to go back. She had a renal cell tumor and she had a nephrectomy, so now she has 1 kidney. And what's her current renal function like?
Let's see.
The only reason I'm asking is, have you ever given any thought, instead of using short-term NSAIDs, to use short-term steroids for her, just on a, you know?
We've done that too.
I'm sorry?
We have done that, but it makes your sugar go haywire.
Yeah, okay,
So,
well, because she has type 2 diabetes, and yeah.
Yeah, it's like, which one do you wreck this week?
Right.
Her current creatinine is 1.11, BUN 13.
Okay, so she's good.
Yeah.
Okay. Yeah, you know, I kind of agree with what, you know, what has been said. This is more of a philosophical, ethical kind of issue as opposed to a therapeutic issue, frankly. You know, and I'm really, really getting annoyed at this whole of getting people off of medications, opioids, okay? Especially in those patients that are doing well, okay? And in this case, a relatively low potency, you know, opioid, hydrocodone, you know, with, you know, not any suggestion that she's overusing, and, you know, no other, you know, evidence of you know, anything that she's doing as far as diversion or anything to that extent. What you're doing is you're trying to run through all these hoops just to try to satisfy perhaps the, you know, the philosophy or the sentiment of a certain group or people, you know, be that, and I'm not really indicting any professional group here. It's just that this happens to be a pharmacy issue. And, you know, I think it's within your purview to suggest or have this person not go to that specific pharmacy. Frankly, you have every right to suggest other places where this person can have their prescriptions filled. And is it the pharmacy in general or a pharmacist in the specific pharmacy that's doing this? I wasn't clear what you said, because you said it's sort of pharmacy dependent, or is it pharmacist dependent?
I'm not entirely sure. As I say, we only have 2 pharmacies in town. One's a Walgreens, one's independent. It's the Walgreens.
Yeah, so you're kind of, okay, I get it. Yeah, it's an access issue too. Yeah, I don't think I would do anything but follow his suggestions, as you heard. I would not, of course, just from a therapeutic, if you want to get into that issue, and you have someone who is well controlled and you want to switch, I think everybody in the audience should know how to do that with respect to looking at the analgesic dosing. Okay. Strategy as they move from one opioid to a second, regardless of the dosage form, immediate release, or perhaps, the extended release dosage forms. I mean, there are certain well-established ways to do that. So that to me is not as critical as just keeping her on the same medicine. It's broken, don't try to fix it. And I just came back from a week in Las Vegas a couple of weeks ago. Whole CDC, 2016 guidelines, which are not in any way, shape, or form evidence-based. Okay, not evidence-based at all. It's purely, totally, with one exception. I think there's 13 guidances, and the last one is evidence-based, but 12 out of the 13, there's no rhyme or reason, for it. And it has created from a national perspective, a nightmare with respect to taking people, or at least the sentiment that you have to, because of the guidelines, start to either discontinue, taper off cold turkey patients. And now what you're seeing across the country in chronic pain patients is an increase in the number of suicides. Reflection because patients cannot get their prescribed medication. Okay, so now, it's like, it's like, where is the evil here? And to me, that's a tragedy. That is an absolute tragedy. Okay, when we're making a lot of decisions on the basis of no evidence, just simply because that's what had come down from the powers to be. But there's no basis. Frankly, there is no basis for it.
So this
audience who deals with chronic pain or knows the guidelines knows that it's based on the evidence, and I understand the good, that some of the good that can happen, but I now am beginning to see the bad outcomes as a result of this perceived need to take people off of opioids where they have had benefit and is the only option for the patient, and it really has provided the best care given all of the specific circumstances to a patient, that can be had, and it's really awful, I think, frankly, and so keep her on it. And suggest to her, you don't really have to, if you don't feel comfortable suggesting a specific pharmacy, that you just say, if you're not happy with this service, then you go somewhere else, and then let her make the decision.
Okay.
Yeah, it's really awful. I feel for you. Yeah.
So I have a question, not so much about getting people off opioids, but about and if you all could help refresh me on the history and also on the pharmacology and treatment recommendations about switching from short-acting to long-acting, because I distinctly remember conversations with top-notch physicians here at New River that occurred 15 years ago, where they said to me, "Oh, I'm moving everybody from short-acting to long-acting because it's just so much better. They don't have to, have the withdrawal at the end of the short-acting dose, and these long-actings are great. And as now, in the era that we're in, I look back on that and thinking that was it. That was how we got into all this trouble. And so, but I guess I haven't thought about it since then. So here is this pharmacy recommending that, and Dr. Bagliani, you said that because she had been on it for longer, she's sort of grandmothered out of the regulation. But is that sound practice otherwise to switch from? I mean, in this case, we're saying no because she's doing well. Is there a clinical reason to switch to long-acting, or was that a marketing strategy? And if so,
I think you may switch to long-acting if there's, in some cases, too much of a pill burden for the patient. That patient wants to not have to take things all the time. So, I mean, under lots of circumstances, it's legit. I mean, we see it. It's done. It's not magic. I mean, if the person is well controlled and you're staying within the same drug, so you're going from immediate release morphine to long acting, or like an MS Contin. Well, it depends on your school of thought. Some would convert to the same dose. Okay, some would maybe err on the side of a little bit less, like not maybe 75%, okay, of that dose. That retitrate perhaps, and always factor in rescue dosing, which, many times is at least what I consider is 10 to 15% of the total daily dose as an immediate release dosage form given to the person. Usually try to stay with the same drug if you could, but you don't have to. And that can be offered every 1 to 2 hours. And again, that's in kind of significant pain sorts of states. But if it's someone well controlled, you're just switching different drug, but not same drug, but different dosage form, and typically it's just the same dose. I mean, and you kind of go from there. I think the key is you always have to monitor the patient, and you always have to keep your eyes every 12 to 24 hours, monitoring that patient over time.
And in her case, in this lady's case, you'd have to go to a different drug, right? There's no long-acting hydrocodone.
No, right. You'd have to, you're suggesting you go to a different, so if you switch to a different opioid,
yeah,
then I would use, there are a myriad of apps and tables that
can convert
analgesic dosing. Okay, in which case, if I was going to switch to a different drug, I would not switch to the full 100% analgesic dose. I'd use something less.
Yeah, very helpful.
Okay, and then retitrate the patient, accordingly.
Thank you.
And then offer rescue if it's necessary. If you think the person is not going to have the same level of control to the switch. I mean, so, but there's lots of different ways to skin the cat. And I'm just offering, one way of doing that, Yeah, but I think you avoid all that by not doing anything. That's kind of what was said.
All the gentlemen over at the Pain Center, do you guys have any other insights, or Dr. Hirschler?
I think the problem we got into here was when we applied the World Health Organization ladder of analgesia to non-malignant pain. It was never meant to be that. And so there is no need to change to a long-acting if the short-acting at a reasonable dose is effective, in my opinion. I'm a little uncomfortable now with every 4 hours because it means it's 180 pills a month that's out there that I don't have any control of. So it used to be when somebody got to QID, I would start to add in a long-acting, but I don't believe anymore that a long-acting plus a short-acting is necessary because, as we discussed here, based upon the DVPRS or WVPRS, what we're looking at is maximizing function, not driving the pain to zero. So you had a treatment success here, and you ran into something that we run into every day, and I think you handled it well, and keep doing what you're doing. We just were talking about how heartening it is to see you guys out there, basically on your own, and how well you do. You do great work.
I agree. Dr. Rexford, do you have any other questions about this, or does anybody else?
I don't.
Excellent.
Appreciate the input.
Thank you again. Guys, we're going to move over to the didactic time, so we can have some time left over for questions. Well, I thought I had it pulled up. Give me 1 second. My computer's decided to run slow today.
It's there somewhere.
It is there. Give me 1 You guys see it? Great. All right. Oh, just click. Just click on the side. Yep.
No, just click on the slide. Okay, I wanted to just briefly address the topic of buprenorphine with the group, and I've entitled this "The Agonist and the Ecstasy" because I like to have creative titles for talks, and so if I could instill that into any of you in the audience who give presentations, I think it's a way to capture the audience sometimes. But for those of you who obviously have seen the painting, this is in Rome at the Vatican. It's the agony and the ecstasy. And of course, this is, Charlton Heston had made sort of this famous in a movie where he played Michelangelo, and was someone who was a sculptor who sort of turned into the need to be a painter and decided to paint the the ceiling of the Sistine Chapel. So a little play on words, agonist and the ecstasy, and I think there's some truth to this title, even when we discuss the topic of buprenorphine. So we're going to talk, as I said, about buprenorphine. Most of you are probably using it or have seen it used, not so much for pain management, but for medication-assisted treatment programs for patients who have opioid use disorder. So roadmap as to where we're going to go with this. Look at some of the challenges affecting West Virginia's response to the epidemic. Describe a little bit about the origin of buprenorphine and its pharmacologic properties. Look at the advantages as an analgesic and its role in MAT, and then look at, through a couple of case studies, how one can manage pain in those who are actually taking buprenorphine for opioid use disorder. So that's kind of where we're going to go with this. So from almost heaven to hell, it's like almost heaven, West Virginia, but West Virginia has sort of gone from almost heaven to hell with respect to the opioid epidemic. So in 2017, as we know, opioid-related death rate was much higher than the United States, almost 50 cases per 100,000 in the population. And I think it's fair to say that West Virginia still has a very distinct shortage when it comes to substance use disorder prevention and treatment programs. Now, this 9 methadone treatment programs is somewhat misleading, because the most recent statistic that I could find, on the internet was 12 programs, but some of the programs I think are double dipping because they have the same address, So I think that the actual number of methadone treatment programs is somewhere between 9 and 10-ish, but woefully low compared, to the geography of the state. About half the counties have no weight prescribers for buprenorphine. Numbers of folks who are in need of opioid use treatment is about 13,000 folks in the state. So it is sort of a difficult situation that we kind of find ourselves in. So this is going to be, so I'm going to throw in a little quiz here and there in this talk too. So this is Botany 101. Okay, so what is this? What is this flower that you're looking at? Okay, I'll give you a second just to look, okay? And then you're going to have to pick one of the answers, okay? So is it the source of poppy seeds? Is it Papaver somniferum? Is it the source of opium? Is it the source of buprenorphine? Or is it all the above, okay? So I think the obvious answer, okay, is that it's all the above. Okay, this is the poppy plant. It is Papaver somniferum. As you know, they make little slits in that little brown part and they latex, and then from which they extract the various opioid alkaloids, okay? So it is the source even of your poppy seeds on your bagel, okay? It comes from the same central plant. Okay, just if you're a bibliophile, and if you're a cinephile, okay, and if you want to learn at least how this sort of for many, several generations of time in the early 19th century, okay, this book, Confessions of an English Opium Eater, okay, by Thomas De Quincey, was sort of the sentinel treatise on the effects of opium addiction, okay? And it was used in some sense as a medical sort of reference for many years prior to anything more substantial or more significant in the area of addiction and the use of opioid. So it's kind of goes into his dealing and his addiction to laudanum, which was tincture, in essence, kind of a tincture of opium that had all of the different alkaloids in it. And it became in 1962, actually, a movie, okay, with Vincent Price. And it's similar titled Confessions of an Opium Eater compared to Confessions of an English Opium Eater. And it was his most challenging physical role, okay? He never made a movie subsequent where he had to have his physical challenge as he had making this. And it has to do, as you'll note here, some of the folks have a Oriental or Chinese surname. And it's because this movie refers to at least in part, what's referred to as the Tong Wars, Tong, which are the Tong group, roughly 1880 to about 1913, was a group of really Chinese gangs that were into prostitution, opium dens, a lot of bad sort of, businesses, so to speak. And so it relates to the Tong wars, in essence, in that sort of time frame. So anyhow, but this is sort of the beginning, okay, of looking at what are the effects of opium in people from a literature standpoint. And it also became, the book became kind of a psychological reference to, in some respects, to in light of his addiction and how it affected him psychologically. Okay, so anyhow, I just wanted to include that as a little side point. Okay, now history, okay? This is the Academy of Ruins in central Greece. Okay, and it's the fortress of the ancient city of Thebes. Okay, so I want you to think, okay, why is Thebes important to this discussion? Okay, because, and you'll note, okay, if I can get this thing, here we go. Okay, it'll be coming up. I have another quiz for it, okay? So which of the following medication are approved for use as part of a medication-assisted treatment program for a person with opioid use disorder. Is it naltrexone, methadone, or buprenorphine? And of course, what do you think? Okay, all right, right. It's all the above, okay? Okay, so here we have now the issue with these. Okay, thebaine, which is one of the alkaloids from the latex from the poppy plant when they cut it, okay, is the derivative of, or a semi-synthetic derivative of thebaine is how they get buprenorphine. That's the connection between buprenorphine and Thebes and thebaine. Okay, so it's a semi-synthetic derivative of one of the naturally occurring alkaloids in the poppy plant. Okay, so it's a lipophilic molecule. For those of you that are into medicinal chemistry, I know that probably is going to freak out lots of folks. You know, it was taught in school, you know, that the various opioids, if you can, they're structurally related in part because they have the same morphine nucleus, okay? So if you look at the green on the morphine, and then you look at the morphine nucleus on buprenorphine minus the additions, it has the same morphine nucleus. So it's related, obviously, okay? It's a very lipophilic molecule. It is liver metabolized, conjugated. It has metabolism via the CYP3A4 system. It's a partial agonist, okay, which means it doesn't fully adhere or connect with the mu receptor or an opioid receptor. It's not a full agonist. So in some sense, you don't have the same effects when it binds to the receptor. And what could be of benefit is there seems to be a sort of a flat dose response with respect to respiratory depression. Okay, so instead of pushing the drug, you keep increasing respiratory depression, you get to a point where you don't, okay, with buprenorphine. So it's a partial agonist. It obviously is an agonist to the mu receptor, which is the primary receptor with respect to analgesia and also many of the side effects associated with opioids. It has sort of an opposite effect in terms of the delta and the kappa antagonists. And perhaps more importantly, when you have a kappa antagonist, okay, that contributes some of what you see as a decline in the need for the person or the craving for the opioid. So it depresses that need or craving, okay, for the opioid. Plus the kappa antagonism may impart some antidepressant activity as well, which could be a benefit for a given patient. The thing you have to realize, buprenorphine is very, very, very potent compared to morphine. It's 25 to 100 times more potent, okay, than morphine. And I sometimes think many people, they forget that potency issue with the drug, but it's a very potent analgesic. So because of its potency, because of some of its pharmacologic characteristics, isn't the greatest thing since sliced bread? Well, there perhaps are advantages. Okay, I alluded to less respiratory depression, useful in patients that perhaps have chronic kidney disease and hepatic disease, less constipation. So some of the side effects are less, but still present. Okay, plus it may have less of an effect on immune function. That's a discussion in of itself. There is some evidence, and actually quite a lot, that suggests acute opioid ingestion, okay, imparts a sort of immunodeficiency type state in a person. It's not, it's funny because patients who do not have pain, but they abuse opioids, okay, there is evidence to suggest they have a higher infection rate. And perhaps that is tied to a relative immunodeficiency imparted because of the opioid. Okay. So it also has minimal effects on sex hormones. I think everybody is aware chronic opioid use does affect sex hormone production. You do have a relative secondary hypogonad type state that you could see with patients long-term opioids. And plus, it does not appear to affect QT. Okay, and that is an issue that you can see with patients that are on, especially high-dose methadone, especially above 100 milligrams. You can see significant QT prolongation at the person at risk to develop arrhythmias, okay, and torsades de plomb, okay, and even potentially it could be a lethal sort of thing. Okay, so there are also some myths associated with it. So everything you see here is a myth. Okay, the drug is not an analgesic, not true. Okay, an X license is required, not true. Okay, etc. So all of these, okay, are false statements. Okay, with respect to its relative safety, with respect to how it can be prescribed, and its abuse potential. Okay, it still carries the baggage, okay, associated with opioid, and that I think is the point to consider. There was a paper that was published, and it's out of England, and it just sort of looks at trying to fit different drugs into a relative likelihood for dependency and physical harm. And if you look at buprenorphine, it's sort of in the middle here. Okay, it's sort of in the middle of physical harm and dependence issue, as opposed to the opposite end of the spectrum with heroin having a high potential for physical harm and a high potential for dependency. Okay, so it's a middle of the road, kind of drug, I think, with respect to those two issues. So what is the FDA approved indications for buprenorphine? It is approved officially for acute chronic pain and for opioid dependency only since 2002. So it's a relatively new indication, okay? So how does it come? It comes in, as you know, in a sublingual dosage or a buccal film. You have a patch that is applied for pain on a Q7-day basis, plus a intravenous or intramuscular parenteral dosage form. Then of recent vintage is the subcutaneous implant, okay? This is for opioid use disorder, for MAT, not for pain management. Okay, and so it's these 4 little pellets that are inserted in the upper arm, okay, sort of minor surgery procedure, lasts for 6 months. You have the ability to replace only once, okay? Plus it's very pricey. So I've not seen a patient with it. The issue is not just the cost, but it only buys you 12 months and then that's it. You can't use it past, okay? So it's just, but that's the latest sort of technology. And I just included dosage forms for the buprenorphine naloxone, okay? The Suboxone, the film, the sublingual. There are differences, frankly. As an example, the 8.2 of the sublingual is equivalent to the 4.2.7 of the film. So, but they're not the same. And there are tables that will tell you which is equivalent to which. Okay. Okay, so here's a case. We have a 27-year-old woman, and she's on Suboxone. She has an opioid dependency. She's admitted to the hospital, and they suspect that she has a perforated gastric ulcer. Okay, she received hydromorphone in the ED. She is taken to the operating room. Okay, post-op person put on a pump with fentanyl. Okay, her last dose of buprenorphine naloxone was approximately a day prior to surgery, and that's her dose is 16. Okay, so what do you do with this person, okay, who's on Suboxone? She has an opioid use disorder. She has to have urgent surgery. She's off the film, Okay, so how do you treat her pain in the hospital? And this is something that comes up, okay? If not the surgery, with patients who come in the hospital with an acute painful issue, they're on Suboxone, how do you treat their pain? And that's the issue. So what's the best answer? Do we continue and then administer short-acting opioids as needed? Do we take her current dose of Suboxone and instead of once or twice, do we go every 6 or every 8 with it? Okay, do we discontinue it, give her what she needs with opioids, or do we perhaps convert her to methadone? Okay, only in the, and with the caveat that if you switch, that has to be switched in the hospital, not as an outpatient. Okay, so any thoughts? Okay, so I have one person here who said B. Okay, the actual approach to this patient is any of them. They're all accepted. Okay, I'm not an advocate of switching to methadone in the hospital. Okay, we have switched patients to a multi-dose regimen. We have used, PRN opioids with benefit, with these sorts of folks. So, I think any of these are considered appropriate. Okay, so I'd be curious to know what people do in the community setting, or when they have patients who are on Suboxone and they have to have a acute admission where how are they treated for their pain. But this is all considered except, okay. Another case, the tox service is consulted for an ED patient. This person was incarcerated and she's pregnant. Okay, and she's 18 weeks pregnant, and she was incarcerated for about a day. So during this time period, she starts to have what looks like withdrawal. Okay, nauseous, irritable, sweaty, anxious, okay, yawning. Okay, she was known to have a lot of IV drug use, and she told the police or the jail folks who brought her that she thinks she's going into withdrawal because she's a heroin user. So how do you fix this person? Okay, and there is a relationship with the buprenorphine, even though it's not within the case per se. Okay, this is and I don't really have a specific right answer because this is difficult. Okay, but what you could consider is if she is truly in the active phase of withdrawal, you can initiate a buprenorphine, okay, not with naloxone, just plain buprenorphine, okay? And the reason is because there's some evidence to suggest that if you were to compare methadone with buprenorphine, you have less, that would be now chronic use, okay, throughout the pregnancy, less neonatal abstinence syndrome compared to buprenorphine or compared to methadone, okay? Now, buprenorphine may also be a better choice to manage her addiction long-term because it's more accessible as opposed to the methadone for the reasons I alluded to. You have less access because you have less methadone treatment programs in the state in particular, and not just here, but other places. Again, try to avoid a combination of Suboxone just because there is sense that if you were to inject the buprenorphine naloxone, somehow that is the person who has the heroin addiction. If she were to inject it, she would withdraw, put the baby at risk, obviously. Okay. And I found this issue that with fetal and maternal concerns about hormone changes, which I could not substantiate. And I went to the reference where this was cited, and it didn't even address it. So be careful when you check references. When statements are cited, when you go to the reference, it's not even there. So that's just a sidebar. Okay. So if in fact you suspect in her case that she is withdrawing, you need to use the COWS scale. Okay, and then begin the induction as I alluded to with the buprenorphine. Okay, so this clinical opioid withdrawal scale is the COWS scale, and it's 11 metrics. Okay, pulse, okay, sweating, restless, pupil, boner, joint aches, runny nose, GI, tremor, yawning, anxiety, and goose flesh, okay, or low erection, and you have goosebumps, okay. And then it's based on a score which is then considered mild, moderate, or severe withdrawal, okay, and that's just for purposes of completeness. I wanted to end with something that relates to the hub and spoke issue. And I don't know if you're aware of this. You are? Okay. Well, Erin Winstanley is a PhD researcher in dependency. And she was initially with the School of Pharmacy, and then I think moved to Neuroscience Institute. But her and her colleagues published a paper this year, okay, in Journal of Substance Abuse Treatment, which showcased a model hub and spoke, 5 hubs, 13 spokes, okay, in an effort to expand the access of MAT to patients or people with opioid use disorder in the state, okay? And long story short, 56 health professionals were trained with this program. Affected 196 patients have been treated. I'm not sure the most recent statistics, okay? And they also indicate that one still, I guess, has to overcome the stigma of addiction, dependency. Okay, and there are regulatory barriers that may limit continued access because these places apparently have to be sort of licensed or registered. They have certain requirements on the part of the patients that have to meet. They have to meet so many times for psychosocial intervention. They have to have so many urine drug tests in a certain time frame. It becomes, especially in this state, an access issue. How do you get patients to fulfill the requirements, okay, of the regulations? And so I mentioned this because it was a successful attempt to use this very mode that you're witnessing today to affect the opioid crisis in this state, okay? So just food for thought. So with that, I'll ask for any questions. If not, I thank you, okay, very much for listening. Okay, thanks.
I have one comment about Suboxone in pregnant women.
Yes.
Suboxone has been around long enough now that we know it's relatively safe in pregnant women. And
Yes.
very little naloxone is actually absorbed sublingually.
Yeah, yeah,
There's
good.
no deleterious effects on the fetus that we can find.
Yeah, that's great.
So in general, when patients are pregnant, we just use Suboxone.
Right, okay, thank you. Cool.
I guess a fun thing to add, you guys have heard quitting cold turkey and kicking the habit. Do you know where that comes from?
No, I'm sure it has a historical basis of some sort.
All right, so it comes from heroin addiction. They used to, when people were treating withdrawal from heroin, there were no medicines and they would lock themselves in a hotel room and suffer through it. And they would get goosebumps, like you said, in the scale.
Right.
And so they look like a cold turkey. So
Yeah,
that's why they call it.
Right. Yeah, okay. Yeah.
Those same individuals would get involuntary kicking movement. So that's why they call it kicking the habit.
Okay.
So both of those
Good. Yeah,
pictures
thanks.
both of those phrases come from opiate use disorder.
Very interesting. Yeah.
Thank you. Yeah.
I might have a question. I might have a couple. I did my 24 hours of training to get my waiver to
Was a slide missing?
prescribe
Okay, but that's okay. Never mind.
Suboxone. I did it back in January, and I'm still not licensed. Things move slowly, and so it's really, I'm trying to keep refreshing myself. Thank you so much for the didactic today.
Yeah,
because I haven't been prescribing. I find the stigma just astounding. The stigma associated with Suboxone, and mostly I'm talking about people in the medical community. And so one question I have is, and I've been wanting to look for this myself, but if anybody on ECHO has easy access to these kinds of things to pass on to Caitlin, to pass on to us, it would be really useful to see the studies that have proven that Suboxone treatment saves lives, so that you can cite actual studies. I've heard just a number of very highly qualified people say that, to the point that I decided to get my waiver and to join our MAT program here, because it just seems so important. At the same time, coming off the opioid crisis and knowing that a lot, that took hold amongst well-meaning professionals because there was misinformation. I've wanted to see, okay, what are the studies? What are the studies? So that's one question. Another question another comment about stigma is that people love to say, well, this is just substituting one for another, and people, they're dependent on it for life. And I understand and have heard and have talked to a lot of people about the fact that it allows people to function. And so it's very different than having opioid use disorder, in a nutshell. At the same time, I think it's an interesting question to ask. Who are the people who might? Are there people who might eventually be able to be tapered off it? And are people looking at that? And what are the qualifications? Or is it? I've had some experts say to me, "It's just too scary. Why? Why would you want to? They're living life. They're successful. They're have jobs, good normal relationships, blah blah blah." At some point, obviously there's the issue of relapses and all that jazz. But is there are there people looking at what makes it possible to taper people off Suboxone treatment eventually, or should we be looking at it?
Yeah, I'll definitely ask. I'm going to see if Dr. Hirschler has any comment. Dr. Hirschler doubles for us on chronic pain and the MAT echo. And we have a very wonderful hub on the MAT echo as we do on the chronic pain, if anybody ever wants me to invite them to talk. But do we have any research, Dr. Hirschler?
Yes, there's lots of research about the efficacy of methadone and buprenorphine in the treatment of opiate use disorder. And methadone goes back a long ways when Nicewander and I forget the other individual's name who started the use of that. But what happens is that people's lifestyles change. With methadone, there's more risk of overdose when they're combined with sedatives, or even an overdose of opiates when someone's on methadone, whereas buprenorphine has a ceiling effect and is somewhat safe for an overdose. But aside from that, all the risky behaviors and comorbid addiction behavior is reduced markedly with maintenance treatment. And I can't cite the studies off the top of my head, but this is something we've known for a while. And patients do beautifully. So they function well. They can be on Suboxone maintenance, and they can live a good life and raise a family and work and be productive and function well in society. And that's an important change versus someone who's chasing a lifestyle of getting another hit of a substance to palliate their dysphoria from the withdrawal or the negative things happening in their lives. So it's a very effective treatment of addiction. Unfortunately, it only addresses opiate use disorder. As far as addiction, it doesn't address methamphetamine and benzodiazepines and alcohol. And so there needs to be more to the treatment because so many of these patients have more than one substance issue going on. There are some isolated just opiate use disorder patients, but often there's comorbid other substance use and psychiatric disorders and medical problems going on. So patients can come off of buprenorphine or Suboxone. Usually I recommend that they do maintenance for about a year to stabilize their lives and give the circuitry a chance to settle down so that they're stable. And then you taper slowly. So it's a percentage decrease that the patients notice. And so if they're on a higher dose, a drop of a couple milligrams is going to be less noticeable. But when they get to lower doses, you even have to go slower. And so it's the percentage drop. And you usually want to drop by 10 to 20% at most per time that you're dropping. And so, I go very slowly with patients to taper off of it. And after a year, some do beautifully and some patients can't tolerate it. And they'll let you know, that I had a lot of cravings when we decreased it and it's just too much for me and I'd rather stay on it. And it's basically the inconvenience of getting the medical care that they require when they're on Suboxone. There's a mandatory therapy component that is included in the treatment with Suboxone. And so it's just a time demand that, that they may no longer want to be on the Suboxone, but their lives can go well. So I'm trying to think what your other questions were.
That was it. That was great. Thank you very much. And
it's a very rewarding work to do. I really enjoy working with patients with addictions. I did my fellowship in addictions back in 1997, so I've been doing this for a long time. And
I'm moving out of a 30-year practice of primary care in one community with one organization to start doing this. And partly because I've heard other people say what you say, and also partly because I just feel compelled by the need.
I was a medical director of a methadone program at the VA in Baltimore for a while. And my experience with buprenorphine, Suboxone versus methadone, is that the functioning is higher. I did a study of work-related issues and, what are people doing for money when they were on methadone. And there was a lot of under-the-table employment or unemployment or thievery and, ways for people to support themselves. And my experience with Suboxone, maybe partly because I was in Baltimore then and I'm in Morgantown now, but my experience is that patients on Suboxone are functioning better and many employed and contributing to society. So it's pretty rewarding work to see them turn around the behaviors associated with the addiction and function well.
Absolutely.
My last question, did Michelangelo have chronic pain after painting the Sistine Chapel? I'm assuming so.
He probably
should have. Yeah.
All right, guys, we are at the end. I appreciate everybody's input. It was a wonderful session. Thank you, Dr. Rexroad, for the case. Thank you, Dr. Ponte, for the didactic. Thank you, everybody, for being awesome.
Thank you, guys.
And we will see you guys in a couple weeks. Bye.